Okay, good morning, friends. Apologies for the technical issue. My name is Bijay Singh. I would like to thank BIOS for running these excellent webinar series. I would like to take this opportunity to thank all the faculty members. We have Mr. Saurabh Aggarwal, who's a shoulder and elbow surgeon at Princess Royal Hospital in Orpington. We got Mr. Roger Van Reit, who unfortunately cannot make it today. He's unwell, who's a well-known elbow surgeon based in London and Belgium. Then we've got Mr. Joideep Phadnis, who's consultant shoulder and elbow surgeon at Brighton University Hospital. And we have Mr. Jagwant Singh, who's consultant orthopedic surgeon, shoulder and elbow at Lewisham Hospital. We have 4 excellent talks. At this point, I would remind you to put your questions through the Q&A section. Because this is a webinar format, please, you will not be able to ask questions verbally. And so the faculty will try and respond to the Q&A in the Q&A section. Try not to use the chat section. At the end, the webinar will be available on the BIOS YouTube channel. One more thanks is to OrthoTV, who are streaming this live across the world in many parts. The first talk is on elbow anatomy and approaches by Saurabh.
Good morning, everybody, and thank you, BIOS, for your kind invitation. I'm Saurabh Aggarwal, upper limb surgeon at Princess Royal University Hospital. So my topic today is elbow anatomy and approaches for the FRCS Orth exam.
Apologies again, the audio wasn't shared. I'm going to try again.
Good morning, everybody, and thank you, BIOS, for your kind invitation. I'm Saurabh Aggarwal, upper limb surgeon at Princess Royal University Hospital. So my topic today is elbow anatomy and approaches for the FRCS Orth exams. Right, so there are 4 extensor and 4 flexor muscles. These are the dynamic stabilizers. So extensors are ECU, EDM, EDC, and ECRB. Flexors are pronator teres, FCR, humerus longus, and FCU. Static stabilizers, lateral and medial ligament. Lateral ligament, 3 parts: radial collateral, annular, and LUCL. LUCL relevant and important. If in terrible triad situation, it doesn't heal properly or not repaired properly, it can give rise to posterolateral rotatory instability. On the medial side, MCL again has 3 parts: your anterior band, posterior, and your oblique band. Anterior band more important. Origin is anteroinferior to the epicondyle. Anterior band is inserted on the sublime tubercle on the anteromedial facet. Then lateral approaches, coccus, modified coccus, EDC split, and Kaplan. For exam purposes, few things. One, start with consent, relevant risks, relevant nerve, then your WHO list, positioning, landmarks, internervous plane, and bring one approach which you've seen and familiar with, and discuss that. But we'll talk about sort of all the possible approaches. So coccus, your internervous plane is anconeus and ECU. So I would always mark my anconeus. So bony landmarks are olecranon, epicondyle, a 0.6 centimeter distal to olecranon. So when I join these dots, this triangle represents anconeus muscle. So the muscle in front will be ECU. So when I cut on this line, as I've done here, I've gone through the coccus internervous plane. Then fascia, unlike medial side, on the lateral side, it's a strong structure. So you incise and repair it in the end as a separate entity to prevent muscle herniation. And then inside, I put my thumb on radial head, I rotate the forearm, and then cut at the equator or slightly anterior to it. So again, indications would be your radial head fractures, your terrible triads, your septic arthritis to the elbow. And in this case, of course, I've replaced it, and some transosseous drills for lateral ligament repair. So picture on the left, that's my coccus. Now remember, with coccus, I am also cutting my LUCL in line of fibers. So to avoid that, if I go in the front and cut my capsule a bit anterior, I will preserve my LUCL. So this becomes a modified coccus approach. EDC split will be further anterior through the EDC muscle. So this paper compared EDC to coccus. So as you can see, EDC, you'll see anterior half of radial head, coccus, you see posterior half of radial head. Now your Mason's classification and your radial head fractures, 80% happens in anterolateral quadrant. So doing a EDC makes sense in those cases. And then of course, if I'm anterior, like I am here, I'm preserving my lateral ulnar collateral ligament. Again, indications are same as coccus. You can use it for your terrible triads, for your radial heads, for your septic elbows. Extended EDC, all it means is you further go up the supracondylar ridge, brachialis is elevated in the front, triceps behind, and then for all those capitulum fractures, which has posterior comminution, and you want to put a posterior plate along with screws, you have to do extended EDC split. And then, of course, in some terrible trials, by doing a extended approach, you can see capsule better. And again, this is a terrible triad. Mr. Phadnis will tell us a lot more in detail. But if your radial head can come out, then you can do your capsular repair from the lateral side only. So retrograde drills and stitches to capsule, replace the head, LUCL repair on the isometric point. And then capitulum fracture is another indication. Kaplan's is a further anterior approach between EDC and ECRB. But remember, the more anterior we go, now pin comes into play. So we have to talk about posterior interosseous nerve in all the lateral approaches. And that's why we pronate to keep the nerve away. So what this paper told us was that from the top of the radial head, if you go 5 centimeters distal, roughly on an average, that's where the first motor branches are given. Now, other papers will say it's 2.5 centimeter. And as we pronate, excursion is a centimeter, nerve will go further distal by a centimeter and falls away from our plane. So every posterolateral approach, we pronate, and for exam purposes and even practically, your safe zone is 3 to 3.5 centimeter. Medial approach, there are 4 flexors. And your 3 approaches, Hotchkiss, Ring, and Taylor. Exam purposes, bring up ring into discussion. Medial approach equals the ulnar nerve. Few points about ulnar nerve that we need to know. Best place to identify, 3 to 4 centimeter proximal to medial epicondyle, next to medial triceps, especially in revision situations or trauma situations. Then look for Osborne's ligament, slide your McDonald's like your carpal tunnel, incise it. Look for medial intermuscular septum, that's your septum. Again, incise it, especially in the revision situations or sort of when you're transposing the nerve anteriorly, because if the septum is not excised, the nerve will flick over it and it will be irritable post-operatively. Then 2 heads of FCU, decompress the nerve, be aware of motor branch to FCU, look at the quality of nerve, make a recording, and then the antebrachial cutaneous nerve. So Hotchkiss is the over-the-top approach or 50-50 approach. So divide your 4 tendons into 2 and then go between FCR and palmaris longus. Indication will be the tip of coronoid fractures. Ring approach, this is the one to bring in the exam because it's through the bed of ulnar nerve. And we've all decompressed ulnar nerves in our practice. So what I'm showing here is white arrow shows ulnar nerve, yellow arrow is FCU. I've sort of decompressed the nerve through the 2 heads of FCU. You can see violet arrow shows ulnar nerve. That's FCU. This is FCU. And then in this case, given the complexity, I have taken off the flexor origin. So this circle is the whole flexor mass. So basically it represents PT, FCR, palmaris longus, and anterior half of FCU. Other half is there. And then as I go through capsule, you can see I'm holding the anterior band of MCL, which is ruptured, and the anteromedial facet, and we can address those with screws or plates. And then another different case, terrible triad, anterior band intact, pulled off the whole facet. Again, medial ring approach, sort of hold this down with a plate, some retrograde drills for capsule, and then a separate small lateral incision for your LCL repair. Again, Mr. Phadnis will talk about it in a lot more detail. Taylor approach is basically where you lift all the 4 flexors anteriorly, as shown here in the AO slides. Indication is coronoid fracture, which is extending into the olecranon. Anterior approach, busy slide, but this is being recorded, this lecture, so you can read it later. For exams, this approach will be brought into discussion in a displaced supracondylar fracture where brachial artery is severed and you've got a pulseless white hand. So again, after liaising with vascular surgeons, you will talk about this approach. So lazy S incision, as you incise the bicipital aponeurosis, which is protecting the artery and nerve, will be straight down to artery. Tag it and send it to vascular surgeons after reducing and K-wiring your supracondylus. And then, of course, if you are shown a trochlea fracture or an anterolateral facet fracture, some elbow surgeons would like to do an anterior approach. So at this stage, in figure D and E, once I elevate the brachialis in the capsule of the coronoid, I'm straight down into the trochlea and the anterolateral facet. So you can discuss that in the exam. Posterior approach, olecranon osteotomy or trap approach. Indications are a comminuted distal humerus intra-articular fracture. Again, I would do it in a lateral position. Some surgeons would do it in a supine. So again, you make your skin flaps, decompress your ulnar nerve. Next step, olecranon osteotomy. So I would put a plate, pre-drill, plate comes off. I would do a chevron osteotomy, bare area, start with a saw, then an osteotome. I have in this case taken anconius with triceps, stitch it back up, temporary wires. I've done a parallel plate, as Mayo told us. Mr. Singh later today will tell us the advantages, disadvantages, indications of parallel versus perpendicular plating. And then, of course, be aware of the radial nerve also. Sometimes it can be a bit distal and it can be very close to your plate. And then finally, I put a plate to repair the olecranon. And this triangular thing is my anconius. So remember, the nerve supply is given off in the spiral groove and comes down in this direction where I'm pointing with the arrow. So by doing a trap flap, triceps, anconius, pedicle flap, I'm preserving the nerve supply. Boyd interval approach, indications, radial heads, Montigias, Some surgeons will address terrible triads through this approach. Again, lateral position, make nice flaps, fascia, leave a little strip, 2-3 millimeters of cuff to repair anconeus, elevate anconeus of the subcutaneous border of ulna. And then as I take off my annular ligament and LUCL of the supinator crest, which is this rounded thing pointed by black arrow, I'm on to radial head. Now I can fix it, replace it. I can put a plate on ulna. I can extend the incision proximally for my terrible triads. And in the end, a transosseous repair to my annular ligament and the whole LUCL complex. Again, very nicely described by Robinson and Mr. Rensburg, if some of you want to have a read on void interval approach. Finally, lateral para-olecranon approach. Again, nice paper by Graham King. Indications: total elbow arthroplasty, distal humerus, comminuted intra-articular fractures, where you're not sure if you can fix it or would you have to replace it. Then distal humerus articular surface fractures involving capitulum and trochlea with anterior and posterior comminution, where again you do not know if you can fix it or would you end up doing a hemi or an elbow replacement depending on age group. This is a good approach. Again, I would do it laterally, like your Boyd, like your trap approaches. I would look for ulnar nerve, lift off anconeus, further go up and take off 1/3 triceps. So medial 2/3 triceps stays onto olecranon, which is your main triceps tendon. So it's a triceps on approach, which means early rehabilitation, early range of motion, and you get a better movement and a better strength. And then, of course, take off MCL, LCL, flexors and extensors. Then you can deliver your humerus or your ulna. Now you can do an elbow replacement. You can fix your humerus as the case may be. We wrote a paper earlier last year on surgical approaches, a comprehensive review. That's a paragraph on this approach from that paper. If you get chance and you feel like you can have a look. And finally, this is my website. On the menu bar, that's my YouTube channel. I've got lots of lectures pertaining to FRCS exams, if some of you want to have a sort of a look. Thank you very much for listening, for your kind attention.
Thank you, Saurabh, for a wonderful talk on the approaches to the elbow. It's one of the key things to identify which approach to use for which fracture. And I think, as they say, that if you've got a good approach, then that's half of your job done. Thank you. Next, we're going to do Roger's talk. I'll let Saurabh introduce Roger. You are on mute, Roger. Saurabh.
Yes. Thank you, Prof. Bijay, for your kind introduction and for the opportunity. Now, Professor Reit, he's a dedicated elbow surgeon. He works at Antwerp University Hospital, Orthoca Group, and also now presently based in Harley Street. He's a renowned elbow surgeon with over 100 peer-reviewed papers on elbow surgery and more than 50 book chapters. He also runs arthroscopy courses in elbow and cadaver courses. He was also a former president of Belgium Elbow and Shoulder Society and a member of many national and international societies. Unfortunately, today, for personal reasons, he cannot attend, but he's kindly given us his recorded presentation, which we'll play for you. And we'll be happy to answer any questions from the candidates.
Thank you.
Hi, my name is Roger van Reit. I was asked to talk about intra-articular distal humerus fractures. I work at Orthopaedic Specialist in Harley Street Specialist Hospital and Orthoca in Antwerp. I'm a designer of Acumed and I'm a designer of the actual elbow by Jake Design. So the incidence of distal humerus fractures is about 5.7 per 100,000 people per year. 2% of adult fractures. Men are younger, with a peak in adolescence, high energy. Women, often osteoporotic with low energy, simple falls. So fall from a standing height accounts for about 60% of distal humerus fractures, and obviously this is very often in brittle bone. There's an anatomical classification. There's obviously an AO classification as always, and I was asked to talk about intra-articular fractures, which is type 13B3, frontal or capitalis shear fracture. We won't go into that in too much detail. And then type 13C, and the C-type fractures are the dreaded ones. Articular simple, metaphyseal simple, articular simple, metaphyseal multifragmentary, or articular multifragmentary everywhere. And this is the one that we all dread. Obviously start with plain radiographs. I literally always will do a CT scan, very often with 3D reconstructions, not just for me, but also for the patient. And now I'm happy to work in a hospital where we can actually print these. So if we feel this is a very complex fracture pattern, I can ask our engineer to print them, and a couple of hours later we'll have it. So treatment options include surgery, osteosynthesis, resection, arthroplasty, hemiarthroplasty, or total elbow. Conservative treatment depends on the fracture, but more importantly, it depends on patient factors, age, activity levels, again, osteoporosis. Was there osteoarthritis, yes or no? If there's a really bad elbow, maybe you don't want to do a heroic osteosynthesis, but you might prefer to go to total elbow replacement immediately. And then general health status, can we actually operate on this patient? This is a 90-year-old patient with a, almost non-displaced distal humerus fracture. She was in a plaster for 2 weeks. We took her out of the plaster for gentle mobilization. This is at 4 weeks, and here you can see the callus that formed at 4 weeks with no displacement, which is obviously very important. And this is her result at 2 months. And I can tell you that even in my hands, or in my hands, this is not generally the result at 2 months after either osteosynthesis or total elbow replacement even. So non-operative versus surgery, there's a little bit of literature there. 3 times more likely to have an unacceptable result, 6 times higher non-union rate. However, in elderly, it might do okay, but it's definitely non-anatomical. The goal for surgery is immediate mobilization. You want to get a perfect or near perfect reduction. That's why we open it up. And you want stability of fixation. So again, patients can start mobilizing immediately. Take care of the skin, because sometimes the skin will make rehab a little bit more difficult, so sometimes you have to protect the patient, despite the fact you want to get them going. An open wound is obviously worse. Surgical outcome is reasonable. Functional range of motion, good to excellent to Mayo performance score, but that's mainly based on pain, as you know. Dash score 20 to 45, not great. Strength 70%, and this is with patients that mobilize early, within 2 weeks. There are some controversies. First controversy is the approach. Do you use lacunar osteotomy versus paratricipital? Do we parallel plate, or do we plate perpendicular? And then last controversy, osteosynthesis versus hemi versus total elbow replacement. Whatever approach you use, you have to identify and protect the ulnar nerve throughout the procedure, and that's important. So always start the procedure with this. This is the approach that I prefer to use, and I haven't used a lacunar osteotomy in probably about 5-6 years. Lateral paralacunar approach, and we'll go into that a little bit in a minute. So tricep sparing versus osteotomy, 67 patients, and they found osteotomy better outcome in patients over 60 years old. But unfortunately, that's the population that may need total elbow replacement, and there was no difference in younger patients, whether you use an osteotomy or not. If you do use an osteotomy for the younger viewers, go through the bare area. Almost everyone has one. Only 3% is continuous, but you can miss it. So even if it is continuous, you can put your saw through it. Yeah. There you see the ulnar nerve, extract the damage, and this is probably one of my last cases where I used lacunar osteotomy a long time ago. So what you do is you look for the bare area, identify it, then grab your knife or scissors, or in this case coagulation, and mark the osteotomy site. We use a chevron osteotomy. There's no real difference whether you use transverse or chevron. It does look a little bit better on post-op X-ray. Okay. So mark it. And we use an oscillating saw. Don't go all the way through the cartilage on the other side, but leave little steps for two reasons. Hopefully this generates less heat and the cartilage is still there, and then secondly, to get some steroidal exit to make it easier for reproduction later on. Some people prefer to put a plate on or screws in or even pinning before. We tend to not do that. But like I said, it's not much of a look good. When you look at this, excellent view of the they can start working from here. And Wilkinson and Stanley published in 2001, 20 years ago, that they did find a better visualization in their anatomical study and less reoperations in a clinical study. However, complications are possible. It's extra hardware, it's longer surgery time, and if it's extra hardware, longer surgery, you do get more complications. This lateral para-olecranon approach was described by Graham King's group in 2013, Journal of Hand Surgery. If you haven't read it, it's definitely worth the read. And it was actually Lee van Rensburg who alerted me to this approach several years ago, and I haven't looked back since. So find the ulnar nerve, protect the ulnar nerve. We use a vessel loop. Don't put any instruments on the vessel loop, so there's no pulling on the nerve because of the instruments. So just put a little knot in it, and that's it. The nerve is safe and happy. Then you can find the posterior capsule, open the posterior capsule, and depending on what you want to do, you can leave it at this, or you can release the ligaments inside out. This was a fracture case where we did a prosthesis, so we just removed a little fragment of the distal humerus. Then, and this is important, identify the posterior part of the olecranon, the subcutaneous border, and leave a little flap of tissue. So leave a little fascia. See, that's what I'm holding up there with my forceps, and that's very important because you'll need to suture it afterwards. And if you cut straight on the subcutaneous tissue, subcutaneous border, then you don't have any tissue to suture later on. So again, same as on the medial side, just go in, and then if you want, you can release ligaments and even dislocate the elbow, or just look underneath and get an excellent view. This was with an older paratricipital approach, the Alonso Yames approach. 79 elbows, about half had triceps on. Only 24 was studied, so that's not a great study. They found no difference with either orthogonal parallel plating, and range of motion was comparable results to olecranon osteotomies. When you do osteosynthesis, do not use K-wires. 3 times higher risk of poor outcome. Really should not be used in adult population. Really don't. Perpendicular plating is classical. It's been tried and tested. There are advantages. You can go up all the way if you want. A little bit less dissection. And placement of the plate is definitely easier. However, they violate the blood supply of the capitellum, which in some fractures is a big deal. So try to avoid stripping the posterior part of the capitellum too much. So increased risk of avascular necrosis. Then Sean O'Driscoll came up with the concept of parallel plating biomechanically. Really depends on the study you read. Probably decreased rotational strength when compared to parallel, but otherwise very, very comparable. It's not perfectly parallel. As you can see here, it's about 160 degrees, so the screws don't interfere with the plates. This is a big list, but we'll go over this quickly, especially for the younger colleagues. This is something that has helped me a lot with my time at Mayo. Even in 2001, Shyam was working on this, and you have his technical objective. So each distal screw should pass through a plate. Each screw should engage a fragment on the opposite side that's also fixed to a plate. An adequate number of screws should be placed in the distal fragments, and that's very important. So try to get screws that are very long, so you have as many fragments as possible. And if you get more screws in each fragment, obviously you get a bigger, a stronger fixation. So you don't have to adhere. This is not the Bible. You don't have to adhere to this, but it does help if you know these rules. Screws should interdigitate, and obviously not if you're using locking plates, but this is one of the reasons why I don't like using locking plates if I can avoid it. Get some compression, don't forget, because this is a site of non-union, so we're always very fixed on the articulation, but non-unions occur in this area. at the subacondyle level, so make sure that compresses. And obviously the plates need to be strong enough, but I think all commercial plates are the same now with regards to strength. This is a 73-year-old male in good health. We fixed it, and he did very well. This is an 85-year-old with a distal humerus fracture, and we always talk to the patient. So I asked them, what do you want? We know from the study from Canada that there is a difference in elderly patients. Probably total elbow replacement are a little bit faster and a little bit less likely to get complications. But this was not a C3 type fracture, so this is still preferred to do we still prefer to do an osteosynthesis in these patients. But we do talk to them. 65-year-old. This was unfortunately unsalvageable. We tried. We couldn't get this, even on the table, we couldn't get this to be fixed. So we used a humeral hemi replacement. So this is ulna remains native, remains intact, and we put a hemi replacement in the elbow. That's the advantage. There's no ulnar component, and you can convert to total elbow replacement if you need. However, no ulnar component may lead to pain and cartilage wear. Revision is not as easy as it seems. So you think, okay, let's just go in and create convert it to a total, but it's not like that. It's obviously an elbow that had a problem, an elbow that had surgery, and if you're an American, there's no FDA approval, but luckily we don't have to worry about that. So you need intact, repairable, or reconstructible medial and lateral columns, although, as you can see in my previous slide, I don't really care too much about the columns, and I've become a little bit more aggressive. I don't tend to fix these. As long as I get a good soft tissue stability, I'm happy. Obviously, the ulna needs to be intact, and the MCL and LCL need to be fixed. Instability, so an ulna that's not working well, is definitely a contraindication. If the bone is really poor, and again, in a patient like this, you can put a hemi in, but obviously it's not going to work well because the ulna is going to be very painful. Results and complications are comparable to osteosynthesis or total elbow replacement. Joideep, who's in this meeting as well, has published on this. And we don't know what the effect of ulnar erosion is. Maybe Joideep can talk about that a little bit later. Total elbow replacement. Mark Frankel and McKee have published this. C3 type fractures, so the really bad ones, comminuted articular surface, comminuted metaphyseal columns. They'll have decreased complication, decreased reoperation rate, better motion, and basically just one surgery instead of multiple surgeries. So we have to talk to the patients, and like I said, I showed earlier, we do osteosynthesis in elderly people for sure, but they have to have good bone, they have to have be active, etc., and otherwise we have some evidence backing us up that maybe they'll do better with total elbow replacement, although the evidence is only 2 years follow-up. So this is a 86-year-old, probably is still fixable. If it's a 24-year-old, we would definitely give it a go. But as you can see, it's a relatively complex fracture. Still with the Kumar Mori, this 1 year post-op. She's happy. I'm happy. Very, very good operation for pain relief. Relatively okay for range of motion, and obviously bad for lifting. So we tell our patients not to lift too much. Not more than 5 kilograms at a time. Not more than 1.5 kilograms repetitively. 3 months post-op. She's had a prosthesis in for now about 5 or 6 years, I think. I was afraid of the shoulder prosthesis, of course, but luckily that hasn't been an issue. A 75-year-old, again, C3 type fracture. You see, we get full range of motion on the table. So what's the literature tell us? This is Dr. Mori, 44 patients, age 70 years or older. 25 patients died at 10 years follow-up. Flexion extension was definitely in the functional range, and like I said, VAS score for pain 0.6, 0.24 on the max. So this is a very good operation for pain, and we all know patients that had osteosynthesis distal humerus that keep complaining about pain. However, 52% complication rate, 11% deep infection, 18% revision. and 42 in surviving patients. So in this series with the Kumar Mori back then, it definitely was not the last surgery, unfortunately, in almost half. David Stanley, the other guru of elbow surgery, 37 patients, similar age, 72 years old. Again, 17 patients died. Flexion extension, nearly functional. Mayoral performance score 90 on average, so excellent score on average. Again, 22% complication, 31% loosening, and 14% revision, so a little bit better than Dr. Morris' group. So in conclusion, it depends on the fracture and the patient. Conservative treatment does play a role in the medically unfit patient. Osteosynthesis is preferred. Hemi is an option, and total elbow replacement is sometimes better, but you have to make up your mind together with the patient and together, obviously based on the fracture. Thank you very much.
That was an excellent talk by Roger, and as we said, unfortunately he couldn't be here. I've got one question, maybe Joideep, you'll probably be able to answer that, is when do you decide between hemi and a total for these non-salvageable distal humerus fractures?
Okay, so hello everyone. So my decision really would be based on the age of the patient and whether the columns are involved. So the hemi is best suited to the very distal articular fractures where the columns are relatively preserved. Often there might be a small medium column extension, and obviously the relatively younger, more active patients. So even if the patient's 70, 80 but active, I'd prefer to go for a hemiarthroplasty. And I'd reserve the total elbows for those people with either pre-existing arthritis, where there's a really severe fracture involving the columns because the hemi's reliant on native stability, or a very geriatric patient where you want to do a linked implant that will just give them a very basic function. So the fact is that in most of the fractures where there is severe articular comminution, the columns aren't actually usually involved. So a hemi is suitable in my hands for most of those cases.
So because, the ligaments needs to be either intact or be repairable for you to do a hemi.
Yes, the ligaments are intact always. They're just attached to the fragments. So it's whether you can fix the ligaments with the fragments reliably. So in a say an open fracture where there's severe soft tissue damage and severe articular bone loss, then a hemi would be less reliable. Yes.
Sorry, Saurabh, carry on.
Yeah, no, thanks, Joideep and Prof. Bijay. I have one more question open to the panel. In these very comminuted distal humerus intra-articular fractures, yes, we are allowed to use free headless screws, even though we want to minimize those, or even threaded wires. But in sort of your experience, have you ever come across a case where you couldn't fix those fragments, at least some of those, and you had to excise them and then use a tricortical iliac crest graft or something?
Yeah, so in the rare situation, again, I'll talk about an open fracture, for instance, because we have severe bone loss in the central part of the joint, or multiple small fragments. What you need to concentrate on is restoring the lateral and medial column. So the medial trochlear and the capitellum. So you don't need to worry too much about the central fragments. What you don't want is them to have AVN and then have metalwork intra-articular. So again, in some of the elderly patients, if you concentrate, it's like, think of the elbow like a train track and the train running on the tracks. If you restore the tracks, you don't need the central bit. So you don't, rather than place lots of metalwork, you can get away with that in the older patients.
So you can excise that central piece to an extent and get away with it.
Yeah, but you need stable fixation of the surrounding fragments.
Perfect. Thank you.
Thank you, Joideep. There's a few more questions. One, you're probably the best one to answer, I guess. Has anyone had to revise a hemi to a TEA?
Yeah, so I've done, I think, 32 hemis now. I haven't had to revise one of my own. And anecdotally, speaking to other people around the country, revision of a hemi to a total is very uncommon for wear. So in the literature, there are the odd case, but it is very uncommon. What the hemis have been revised for have been for loosening of the stem or infection. And I've revised one hemi sent to me from elsewhere for instability. And that was because the implant was placed in Mower Rotation. So when I revised that, I changed that to a total for safety rather than... So I still revised the stem to get the rotation right, but change that to a total elbow.
Another question is, what do you do for the very distal fractures with the radial head fracture is not salvageable? Is hemi contraindicated?
Yeah, so that's a very, very rare situation, firstly, where you would have such a severe radial head fracture and a unreconstructable distal humerus. So I haven't seen that situation, and I can guess that most people wouldn't have seen that situation. However, yes, the hemi, you need stability. So that would be relatively contraindicated unless you can fix the radial head. If you really can't fix the radial head and the patient is too young for a total elbow, then you could, in theory, replace the radial head with the poly radial head from the latitude system and do a hemi. However, I would emphasize that is extremely rare, and I've never done or encountered that situation. So that's just me off the top of my head.
Thank you, Joideep. Saurabh, for you, what medial approach is the best for the sublime tubercle and also for open reduction of supracondylar? I think it's more pediatric, but we can take it here as well. Supracondylar fractures with possible brachial artery injury. How do you decide which approach to use, anterolateral versus anterior? Right, and is the global approach to elbow and Mower approach the same?
Right, okay. So from medial approach to sublime tubercle, you can pick either of the two approaches. You can do over-the-top Hotchkiss approach. So your plane will be between, some book says FCR and palmaris longus, other book says between palmaris longus and your FCU. But practically it's very hard to know where you are. You see your ulnar nerve and sort of go anterior to it. Or you can even use David ring approach, the FCU split approach through the bed of ulnar nerve. Only thing here is how to prevent damage to the anterior band of MCL. So once you've decompressed your ulnar nerve, I always feel the sublime tubercle, and then my dissection is further up, further anterior to it. So then I know I'm automatically not doing any damage to the anterior band. So that's the key here in this approach. You can say either or in the exam. Practically, I'm more comfortable with the David ring approach, so I would do that.
Thank you.
And then you were saying supracondylar, open supracondylar.
No, with the vascular injury, not open.
Okay. So first of all, one thing to appreciate in supracondylars is brachial artery can have intimal tears. It can go into spasm, or which can result in radial pulses not being felt. So one needs to be aware of that. Second thing is, okay, let's assume a situation where it is actually severed. So once you've spoken to vascular surgeons, and if the fracture is very displaced, I would still do a double approach. I would stick to first. So I would first reduce my fracture, as I would do any supracondylars which I cannot reduce close. So I would do my traditional lateral approach. I would reduce it. I would flex it completely to make sure it's reduced and there is no sort of catching of vessel or brachialis in between the fracture fragments. I would K-wire it. And then if the pulses haven't been restored, then I would do an anterior approach after liaising with vascular surgeons and tag it. So I would start from a familiar territory, a lateral approach. Then if I feel pulses haven't come back, then I would go anterior. So I'll do a dual approach.
Thank you, Saurabh. I think for the sake of time, we should move on. Next, we've got a talk by Joideep. Looking forward to this fantastic talk. I do apologize to the attendees that it is slightly longer, but I can assure you that it's worth your while listening to this talk. Joideep is a colleague and a consultant at Brighton University Hospital. I don't know whether he likes to say elbow and shoulder surgeon or just elbow surgeon, but he's the master of elbow surgery, certainly in the southeast of England. I'm going to share this presentation.
My name's Joideep Phadnis. I'm an elbow specialist working in Brighton in the UK, and my talk today is going to be about understanding rotatory fracture dislocations, and this encompasses terrible triad fracture dislocations. The objectives are really going to be to have an emphasis on understanding these injuries so we can treat them better. So we're going to do this by discussing the Patho Anatomy, recognizing the specific patterns of injury that are included, and how this affects our decision making and treating patients with these injuries. So we know that the elbow has primary and secondary stabilizers, the primary stabilizers being the coronoid, the medial collateral and lateral collateral ligament. And when we talk about the coronoid, we're talking about the bony congruency of the ulnohumeral joint. And the secondary stabilizers are the common flex origin, common extensor origin, and the radial head. We know that when we have a fracture and we have these soft tissue structures injured, the radial head becomes more important and becomes upregulated as a stabilizer of the elbow. The forces that lead to these injuries are a combination including axial load, varus and valgus moments, as well as internal and external rotation forces to the ulnohumeral joint. So internal rotation, i.e. pronation in the axial plane, and external rotation will put differential stresses on the ligaments. And it's this combination of forces that will lead to two characteristic patterns of rotatory fracture dislocation. The first, which is analogous to the terrible triad injuries, the posterolateral pattern, where there's a predominantly valgus and external rotation force. Whereas in the posteromedial pattern, there's a predominantly varus and internal rotation force. And recognizing which injury type we're dealing with is important. And the bony injuries that we see on the X-ray and CT will allow us to recognize the patterns. How do we do this? So if you look at the radial head firstly, in the posteromedial pattern, the radial head will tend to be intact because the elbow is internally rotated and subluxated. Therefore, the radial head's not been fractured, either in shearing, as happens in the valgus posterolateral pattern, or by impaction when there's valgus against the capitellum. So in the posterolateral pattern, the radial head will be fractured. The coronoid in the posterolateral terrible triad type pattern will tend to be anterolateral and tend to be smaller, and in the posteromedial pattern will involve this anteromedial aspect of the coronoid, will often be concave shaped and may extend further either into the sublime tubercle or into the anterolateral area as well. And remember that the reason for recognizing these bony patterns is that they infer and dictate what soft tissue injury is present. The most important soft tissue injury to be aware of, because it's the one that always needs fixing, is the lateral collateral ligament. This arises from the supinator crest of the ulna and inserts onto the lateral epicondyle, and it's confluent with the annular ligament and the radial collateral ligament, and it forms this hammock structure that is lifting and cradling the radial head up. It's responsible for varus and external rotation stability, and it's injured in both PLRI and PMRI patterns. In the PLRI pattern, it tends to be injured with an external rotation force, where we see this drop sign because the ulna has been rotated externally relative to the humerus, as you see on the left. And in the PMRI pattern, it's predominantly a varus injury, as you can see in the right image. The medial collateral ligament is a really stiff, stout structure, and the anterior band of the medial collateral is the strongest of the ligaments in the elbow. The posterior band, on the other hand, is thin and is a condensation of the capsule. And the two together are responsible for valgus and internal rotation stability. The anterior band is injured in the PLRI valgus pattern. Sometimes it's intact and the elbow pivots around it. And the posterior band tends to be injured in the PMRI internal rotation. So it's torn with internal rotation and contributes to instability in the PMRI pattern. Remember that the MCL tends to be compensated well by intact common flexors, and hence, unless you have this situation where they're exploded apart, we can treat the MCL non-operatively in many of these injuries. So in the sagittal, so the coronoid's role is as a sagittal plane stabilizer. It provides an anterior buttress to dislocation, but it's also important for coronal plane stability, where the anterior medial facet resists varus instability. Don't forget, it's also important for axial and rotatory stability, particularly the anterior medial facet against internal rotation, where the trochlea comes into contact with the anterior medial facet. And in this situation, this is where we might tear the lateral collateral ligament from varus. It has a less important role with external rotation stability, because predominantly this is provided by the radial head. And in this situation, the lateral ligament will tear because of external rotation force rather than a varus injury. And you can notice that the tip region, i.e. the coronoid apex, doesn't really provide any significant stability from what I've shown you. We classify coronoid fractures ideally using a CT-based classification system, as it's very important to recognize what area of the coronoid is fractured. As I've said, this will infer the ligament injuries and the instability pattern. And the emphasis of the O'Driscoll classification is on recognizing these anteromedial, facet, and basal fractures, where the tip fracture is not important. And remember, the anteromedial facet fractures can extend into the sublime tubercle, but most commonly they're in this region of the anteromedial slope of the coronoid, and they typically form this concave shaped defect from the medial trochlea. The Wrightington classification is very similar to the O'Driscoll in that it's recognizing the anteromedial and basal fractures, and it's a simplified version talking about an anteromedial facet and an anterolateral facet. It's important, I think, to emphasize posteromedial varus instability, as this is sometimes misunderstood. Remember, this is an internal rotation injury with combined varus that leads to varus subluxation of the ulnar-humeral joint, and typically gives us a lateral collateral ligament avulsion in varus, an internal rotation injury to the posterior band of the MCL, and an anteromedial impaction fracture of the coronoid, which is typically this concave shape. And this is why you can see the radial head is spared in these injuries, because it's a varus subluxation. This injury is really important to recognize, because the chronic posteromedial and varus subluxation leads to increased joint reaction forces at the medial trochlear articulation, which can lead to rapid post-traumatic arthritis. So we want to recognize these coronoid fractures and treat this injury early and effectively to avoid the situation where we might have in this patient who needed an early total elbow replacement. So with the knowledge that these anteromedial coronoid fractures are really important not to miss, do they all need fixing? And can any of these be treated non-operatively? And if so, which? And how do we recognize which of these injuries can be treated non-operatively? Is there a role just to repair the lateral ligament? And if so, how do we decide without causing problems with our patients? So let's look at some of the literature. This biomechanical study by Graham King's group showed that all the sublime tubercle fractures, i.e. those involving the sublime tubercle type 3s, needed fixation because fixation of the lateral ligament alone wasn't enough. However, the smaller subtype 1, i.e. those common anteromedial fractures, could be treated with lateral ligament repair alone. And the figure they thought about was around 5 millimeters in size as being the critical point for lateral ligament repair versus lateral ligament and coronoid fixation. This clinical study by Antonio Fururia reported 38 patients who were treated non-operatively with an anteromedial coronoid fracture. But the prerequisite were that all had to have an intact sublime tubercle, the joint was congruent under reduction, and the coronoid height was left at less than 50%. But remember, in this study, they immobilized the patient for 4 weeks in order to allow the lateral ligament to heal. But despite this, 10% had poor results, and this was because of lateral ligament insufficiency. This is a study that we performed with 43 patients, and our findings were similar in that the patients that could be treated non-operatively had to have an intact sublime tubercle and a congruent joint reduction on imaging. And we used clinical testing to identify whether the lateral ligament was incompetent. This was the posterolateral draw test, and whether the coronoid component of the injury led to varus grinding and subluxation, and this is called a varus stress test. And we found our protocol was that if we found the lateral ligament was gone but the varus stress test was negative, we would go ahead and fix the lateral ligament alone. This is the posterolateral draw test, and it's used to identify lateral ligament insufficiency. It's highly sensitive and specific for identifying this problem. And the varus stress test, which is done in clinic and radiographically in theatre, where you can feel grinding if the trochlea rides into that coronoid injury. When we look back at the cases, we found that the patients who had coronoid fractures over 6 millimeters in size were the ones who always required surgical stabilization. So this is in keeping with the other studies regarding the size of the fragment. So if we go ahead and fix the coronoid fracture, what techniques can we use? We can use arthroscopic, using screws from posterior to anterior, and more commonly open procedures from anterior to posterior, or PA or plates. What I would recommend against is using suture techniques to fix the coronoid. These are most commonly used when the coronoid fragments are very small, and what I've shown you so far is that these tip fractures and even the small anteromedial fractures don't need fixation, and hence there's no role in my practice for using sutures to fix the coronoid or tighten the anterior capsule. Coronoid fractures in my practice there is a real role for arthroscopic fixation. If you have the arthroscopic experience to do this, it avoids the morbidity of a medial exposure, and I use this technique when the coronoid fracture is large enough and it's in one large fragment, and we have to do PA fixation in this situation. It really does avoid morbidity of a medial approach. However, if I need to fix a larger coronoid, or it's comminuted, or I need to bone graft the coronoid, then I'll use a medial approach. It allows me full access to the coronoid. I can address the medial soft tissue structures, and I can place plates and screws. And this is why I don't tend to use lateral or anterior techniques to fix the coronoid. This is the most common approach I would use to fix the coronoid. It's the over-the-top approach, and it goes through the interval between the anterior head of FCU and palmaris, and we can extend it up the medial column to get more view. We can address MCL tears through this approach as well. And there are other approaches which I won't go into, but this is the main one to use. So what's the role of the radial head in this in these injuries? Well, the radial head's responsible for valgus, external rotation, and longitudinal stability, as I've already shown you, and it's critical in a fracture dislocation situation. So we shouldn't excise it. What happens if we excise the radial head with residual instability of the rest of the joint is that we get rapid onset arthritis because of the increased forces that go through the ulnar humeral joint. Now, often these arthritic changes are asymptomatic many years later, but we know for sure that they do develop as compared to an elbow with a radial head in place. So do we fix or replace the radial head? Well, for me, I consider replacement in fractures where there's a complete articular fracture, i.e. there's no continuity between the head fragments and the shaft of the radius, and it includes the neck. If there's multiple fragments, or the fragments are very small but important to stability. And there's no hard and fast rules on the number of fragments in my practice, although we know that if you get over 3 fragments, it becomes more difficult, and we have to really consider every patient individually. If I'm performing a fixation, I try and avoid the use of plates where possible, and if the neck's involved, I'll use these tripod screws to gain stability into the neck. However, there are certainly the occasional situations when we do have to use a plate, particularly in the younger patients where we want to avoid replacement, or if there's diaphyseal extension down towards the radial shaft. So when we're doing a radial head replacement, we have to think about the bearing surface, the shape, whether it's anatomic or non-anatomic, and our fixation method when we're choosing a radial head replacement. But actually more important than all of this is the correct sizing and length of the implant you place. In terms of sizing, remember that the radial head is slightly oval shaped rather than round, and when we're sizing, it's better to use the lesser diameter of the curvature of the radial head to choose, and it means we err on undersizing the implant, which is good. The way I get the length right is I use the intraoperative landmark of the lesser sigmoid notch. And remember that the head should never be proud of this landmark, which we can see intraoperatively, and it gives us the perfect view to line up the radial head. And I use this over radiographic methods. This is what happens with overstuffing. You see a widened lateral ulnar humeral joint with persistent varus and rotatory subluxation. Don't forget about aligning the radial head correctly. The radial neck aligns with the axis of forearm rotation, which lines up with the ulnar styloid. And a good surrogate for this intraoperatively is the distal aspect of the radial tuberosity. So aim for the stem tip to be lined up with the distal aspect of the radial tuberosity. Let's now put everything we've discussed into a model where we discuss the elbow as having 3 columns. The medial column being the anteromedial facet of the coronoid with the medial trochlear, and the lateral column being the radial head and capitellum, with the central, less important column being the anterolateral facet of the coronoid with the lateral trochlear ridge. If we think of these columns supporting a roof of stability with our lateral and medial collateral ligaments, and we then think about a simple elbow dislocation where we lose the lateral and medial collateral ligaments and the soft tissue structures, these tend to remain stable. Why? Because we have these columns intact and supporting our roof. If we now take away the anterolateral column, I have an anterolateral coronoid fracture. This is still a stable situation relatively because we have the important medial and lateral columns intact, so our roof remains stable. Now, if we add a radial head fracture like we get in a terrible triad situation, then we have gross instability because we've lost our lateral column and our roof tips down and we get dislocation. And in this scenario, simply repairing the medial sided structures isn't going to support the roof, and we need to support the roof back up by repairing or replacing the radial head. This gives us stability again. So why do we repair the lateral collateral ligament in this situation if we have stability? Well, don't forget we're talking about a two-dimensional concept, and the lateral collateral ligament provides this axial rotatory stability. So the lateral ligament repair will restore the rotatory axial 3D stability of the elbow, and this is critical for this, as well as, of course, varus stability. Now let's think about posteromedial instability with a small anteromedial coronoid fracture. Well, in this situation, we're going to get tipping of the roof into this, but because it's a small fracture, we may achieve stability with a robust lateral collateral ligament repair. However, with a larger coronoid fracture, we're going to have much more instability, and this is that posteromedial situation where we get the trochlea driving into the coronoid defect on the anteromedial aspect and causing this grinding sensation. And in this situation, a lateral ligament repair alone isn't going to be enough. We need to restore the medial anteromedial buttress and possibly even repair the posteromedial ligament for that rotatory component of the injury. So just finally to touch on some of the adjuvant treatments that are around for rotatory fracture dislocations. Internal bracing, I'm a big fan of this, both in the acute and chronic situation. And acutely, I would use it when the soft tissues are really shredded. You've got almost an explosion of the soft tissues, and we can't rely on primary fixation with a suture anchor. And there's nothing complicated about internal bracing. We're essentially creating a suture-based ligament, either by placing anchors at either end of the ligament or transosseous tunnels with a braided suture. The internal joint stabilizer is a very clever device that I do like, but for me, its role really is in revision situations to get us out of trouble in highly unstable elbows or protect ligament reconstruction. So I wouldn't recommend its use for the acute scenario, as if you follow the principles we've discussed, it won't be necessary. And then formal external fixation I use very rarely, maybe once a year. And the situation I would use this in is for a vascular injury, perhaps with compartment syndrome, or an infected elbow with ligament insufficiency. So what are the rehab principles I employ? We go for immediate range of motion afterwards. We do this with a supine rehab program to utilize gravity compressive force, and we avoid varus torque on the elbow for 6 weeks, i.e. no shoulder abduction beyond 45 degrees and no weight bearing through the arm. But it's critical that the patient gets moving immediately to utilize the contraction of those dynamic stabilizers to compress and rehab the elbow. I don't use any bracing or splinting, as I find this is unnecessary if we get primary stability with our surgery. So just to summarize, we've discussed how to understand and interpret imaging to assess what pattern of instability you're dealing with. This is really important so that we can individually tailor the surgery to the specific injury pattern in order to choose which structures are most important to fix. I'd urge you all to assess the imaging in detail, and with particular emphasis on looking at the coronoid and understanding whether that coronoid fracture that you have is contributing to stability and whether it needs fixing or not. And remember, all lateral collateral ligaments need repair in every one of these injuries. And never excise the radial head, as it's particularly important in these rotatory fracture dislocations. Thank you very much for listening.
Thank you, John. On its own, excellent presentation. So one of the things that I sometimes struggle with is how to decide which approach. I mean, decided there's a coronoid fracture as well as a radial head. When it's a simple dislocation, when it's a simpler with a radial head fracture and the medial side looks intact or coronoid is not broken, it's easier. How do you decide whether you're going to use a single posterior approach or you're going to use a parallel incisions for tackling these?
So one question is whether you need to fix both sides, and so the talk has sort of covered that, the decision making. So in terms of incisions, I did a fellowship with Greg Bain, and he sort of popularized the extensile posterior approach. But in my own practice, I've gone away from that. So I much prefer using separate medial and lateral incisions, and it means we really don't get any seromas. We move straight down to the structures of interest, and you retain that posterior soft tissue. And I think the infection rate and the hematoma rate with the large flaps that we create posteriorly, it is just unnecessary, I think, when we're doing so I would always plan my surgery based on the imaging and examination, usually start with the lateral side and then make a separate medial incision.
I agree with Joy. I found that approaches are really better than using a big approach and then having the risk of seroma and infection and skin problems.
Joideep? Yeah, can you hear me?
Yes.
Excellent talk as always. I've heard lots of your talks. Now I have one question. How or what dictates whether you would use an anatomic radial head replacement or a non-anatomic? Any particular sort of cues to it, or is the jury still out? How do you decide?
The jury is still out, really. The advantages, there are some theoretical biomechanical advantages to the anatomic radial head, but the flip side is that you need to put it in the correct anatomic rotation. So I've used both. My preference initially was a non-anatomic press fit pyrocarbon coated radial head. They stopped manufacturing the pyrocarbon, so now we're using the anatomic radial heads. What I would say is that you don't need to use radial heads with very long stems. There are some implants out there with stems that go beyond the radial tuberosity all the way down, and I think it's unnecessary. My experience with the pyrocarbons were that they had very short stems, but we've got hardly any loosening. So if you're going to use a press fit, try and avoid losing bone stock with longer stems. But the jury's out on the anatomic component of it.
Sure. And as you said in your presentation, key is the height, because you don't want to overstuff.
Yeah.
Equally, you do not want to understuff a lot also.
Yeah.
And the key is the diameter of the radial head. So err on the smaller size.
Yeah.
Now, am I right in understanding that so far as rotation is concerned, because radial head is oval, it is a bit forgiving in the sense you can get away even with 30 degrees of malrotation. Am I correct in understanding that?
What do you mean by malrotation?
So, if the head is not put in a correct sort of that oval alignment.
Yeah. So you're talking about if you use an anatomic radial head.
So if you're using a porous-coated press-fit anatomical head, so you've got the size of the head right, you've got the height right, but you've not got the rotation right, that oval part.
Okay. So I suppose it depends what you mean by getting away with it. So if you're doing an anatomic head shape, The reason you should be doing it is because it better replicates the contact forces against the capitella. So I think if you're not in the correct rotation, you're not going to achieve that goal, but you will still get away with it in terms of stability of the joint. But then that means you don't need to use an anatomic radial head.
So rotation is not that forgiving.
Yeah, I think the biomechanical studies show that are based on it being in the correct rotation. So I don't know the data, but if it's not in the correct rotation, then you're not achieving that goal. It's just that you will get away with it because what we're looking at is stability, not at the wear pattern.
Okay, thank you very much.
There's a question, Joideep. In the young patient with badly malunited radial head and stiffness, would you excise the radial head and do an arthrolysis, or is there any other alternative?
Yes, that's a good question. And so if you have a malunion of the radial head with stiffness following an instability, it all depends on whether when you excise the radial head, because that is the best way of restoring the rotational movement and doing an arthrolysis, whether the elbow remains stable or not. So in those situations, I've tended to always have a radial head replacement available to put it in. But there are definitely situations where I've felt the elbow is totally stable because the ligaments have healed. And then it is reasonable just to simply excise the radial head and perform an arthrolysis. But we don't know for sure which one is best. We do know that without the radial head, that elbow will get arthritis slightly earlier, but you may hesitate about putting an implant in a stable situation.
Can I ask something?
Yes,
Yeah.
Jagwant, go on.
Excellent talk, Joideep. You mentioned about the suture fixation for the so we understand that if it's involving the anterior medial facet, doing a suture fixation is not going to sort the problem. It needs a plate or a screw. But there are some surgeons who would fix the radial head or replace the radial head, and they would still put suture in the anterolateral fragment or in the capsule there. What would you say about that?
I personally don't think that's important. And I know there's some very good, prominent surgeons who do that. And they would say that there's some proprioceptive benefit from the capsule to doing that. But if you think like we went through the columns, that anterolateral part really isn't important as long as you address the other structures correctly. And the reason most people use sutures is they say the coronoid fragments are too small for fixation. And I've shown you in the talk that if the coronoid fractures are so small, less than 5 millimeters, particularly in the anterolateral part, they're not important for stability. So I don't think you gain very much by adding sutures. Does it cause a problem? Probably not, but I think it's unnecessary.
And it has no relation to the drop sign.
No, that's all from the lateral ligament. So I would spend 20 minutes more concentrating on your lateral ligament structure or adding some robustness to that with a brace if you're worried, rather than spending 20 minutes drilling holes and putting sutures in.
What do you say about when intraoperatively you have the drop sign, but when you start eccentric exercises and the patient is awake, there will be some correction of the drop sign when the biceps and the brachialis start to contract?
Yeah, so Graham King's published on that. He's talked about using a rehab program to help. But so I think if you have a drop sign post-op, you might want to try that. But we shouldn't be expecting to have a drop sign intraoperatively. So you shouldn't leave the theatre with a drop sign saying, I'm going to use exercises. You need to then readdress why you've got that, because you don't want to leave theatre with any instability.
Got you.
Thank you, Joideep.
Thank you, Joideep.
Oh. Okay. So any further questions on...
I think for time we should just carry on to the next one, Saurabh.
Okay, sure. So our next speaker is Mr. Jagwant Singh. He's a friend and a colleague. He trained from Wrightington and now he's a shoulder and elbow surgeon at Queen Elizabeth Hospital, Woolwich. and he's very active in academics. So over to you, Jagwant.
Good morning, everybody. My name is Jagwant Singh. I'm one of the elbow and shoulder surgeons at Lewisham and Greenwich Trust. Thanks to BIOS for giving me this opportunity. My talk is on different plating techniques in distal humerus fractures. We will be talking about the orthogonal plating, then the principles of parallel plating, the comparison between the two, and some case examples. Distal humerus fractures are complex injuries. Using parallel or orthogonal plating depends on fracture pattern and surgeon's preference. The key for successfully treating distal humerus fractures is anatomic reduction intraoperatively and ensuring that we have a stable fixation which allows for early range of movement and preventing stiffness of the elbow. When we talk about orthogonal plating, this was originally recommended by AO. Jesse Jupiter and his group described the technique and their first results from a retrospective series in 1985. It involves fixation of the articular fragment with one or two screws placed in a coronal plane, followed by plate fixation. This technique did have limitations. The concept of parallel plating was conceived because some surgeons felt that orthogonal plating failed to provide adequate fixation of the distal fragments. This suboptimal anchorage between the distal articular fragment and the shaft of the humerus led to the failure at the supracondylar level. The reason for this was there was limited fixation due to limited screw and the limited screw length. Also, if we were protecting the fixation, this led to immobilization for a longer time and stiffness of the elbow. The rationale for the parallel plating was that longer and more screws in the articular fragment would give us a better stability and then also allow for supracondylar compression, which a posterolateral plate failed to give. Dr. O'Driscoll and his team from Mayo Clinic gave us these principles of parallel plating. There are 8 principles, 6 of them are related to screw and 2 to the plate fixation. So the Mayo team told us about that each screw should pass through the plate, engage a fragment onto the opposite side, which is also fixed with the plate. Adequate number of screws should be placed in the distal fragments, and the screws should be as long as possible. Engage in as many articular fragments as possible and create a kind of an interdigitation lock, fixed angle structure, linking the columns together. Regarding the plate, we have to try and achieve compression at the supracondylar level to prevent the non-union, which we saw with the orthogonal plates at the supracondylar level, and also that the plates should be strong and stiff enough to prevent any breaking or bending before the union occurs. So this is how we see that as many screws as possible, they're interdigitating and holding the construct with closing the arch. And it's just like a reinforced concrete type of a construct. When we compare the orthogonal to the parallel plating, in terms of biomechanical studies, there are conflicting outcomes. But all these studies do show similar kind of a mechanical stiffness and fracture stabilization. Some studies do favoring the orthogonal and some parallel types of fixation. When we talk about varus loading, screw loosening, and axial and sagittal loading, the parallel plating does seem to have some benefit. Fixation does depend on the bone quality, but when we have an intra-articular fracture with metaphyseal defects, parallel plating is recommended. The superiority of the parallel plating is especially relevant in cases where we have limited bone contact. So for any intra-articular fracture with metaphyseal defects, parallel plating does seem to have a little edge. Looking at clinical studies then, this is a meta-analysis comparing 6 different randomized controlled trials, nearly 350 patients. Orthogonal plating does take longer to union time, but there is no difference in clinical outcomes and complication rates. It's only that the parallel plating is slightly superior in terms of fracture healing times. Thus, to conclude, both these techniques have satisfactory outcomes. When to use orthogonal or parallel plating depends more on the fracture pattern, the quality of the bone, and also the surgeon's preference. For a successful management of a distal humerus fractures, it's important to know the morphology of the fracture with preoperative CT scans, intraoperatively to achieve anatomic reduction, and get a stable construct so that we can allow early range of mobilization in patients and prevent future complications. I'll be taking a few case examples. The first patient is a 48-year-old skateboarder. He fell down, sustaining a distal humerus fracture. CT scan revealed a T-type configuration of the distal humerus fracture. Now, in an FRCS exam, the examiner will be expecting you to discuss the approach, the principles of fixation, parallel plating, and the anatomy with regards to ulnar nerve, radial nerve. We fixed this on the principles of parallel plating, and the olecranon osteotomy has been closed with the tension bandwire. This is bony union achieved at 3 months. So it's important to talk about the approach, which Saurabh has already discussed. Another patient, 53-year-old, he has got a coronal element to his fracture here, as we can see. This required multiple headless cannulated screws to fix the articular fragments, and then orthogonal plating. Because of the comminution, we protected it for some time in the plaster, and it achieved union. So that is it from my side. I'm happy to take on any questions. Thank you.
Jagwant, thank you very much. It's an important sort of topic and very important to get head around as to when to use orthogonal plate, because we will always use parallel plate. That's the instinct. But there are some fracture patterns where I feel one should use orthogonal plating system. So thank you very much.
I think it's just the fracture which dictates it, and parallel plating should be your go-to method. But if the fracture is of a morphology which requires coronal screws and a perpendicular plating, we should use that in selective cases.
Absolutely. Can I, Prof. Bijay, is it possible to bring the last two slides where Jagwant has put a orthogonal plate?
One second. So whilst I load that, can I ask, you nicely gave that demonstration of fixing the osteotomy, one with tension band wire and one with a plate.
Yes.
Now, both you, Joideep, and Saurabh, when do you decide, how do you decide which one to use? Because I personally use a long canceller screw and a tension band wire. That's been my very standard way of fixing the osteotomies.
Sure. Of course, Joideep is the master of elbow. I can attempt to answer your question and Joideep can then correct me. So I feel with tension band, it's not a benign device. It's not easy to get a very perfect tension band, if you like. So the wires become prominent. They impinge on the skin, they back out, they can perforate the skin. So and again, with the canceller screw, I know, Prof, that's why you're a professor, you have a lot of experience. Screw has to be directed, like it's not that easy to put a simple straight one canceller screw and achieve union. It has to go in a particular direction, which comes with experience. So I stick to a simpler plate because I feel it's a bit low profile, and the chance of me removing the plate is a bit less compared to tension band. So that's my rationale of using a plate in an olecranon and osteotomy.
I would do a tension suture now. I'm doing an osteotomy because I think that is a much better way of dealing with this. And after fixing a distal humerus, you're tired and you want to just quickly do the operation. I think tension suture is going to be more and more used for fixing the osteotomies.
Yeah, sure. Writing. Joideep, what are your thoughts?
So, firstly, with practice and using learning the parallelecranon approach, you will need the osteotomy less. But it's totally reasonable to do an osteotomy if you to get it right. So, if I'm doing an osteotomy, my personal way is to use a canceller screw, so a partially threaded screw. As you said, Saurabh, there are a couple of points you need to be aware of. So it needs to be in the line of the diaphysis to avoid the varus angle in the ulna, and also on the lateral view. And I put a tension suture for rotational control, like Bijay instead of tension wire. The trick is to do it early. So whatever device you're going to do it at the beginning. So I pre-drill it, tap it, and it has to be usually about 90 to 100 millimeters to engage the diaphysis. And any of the techniques are fine, but they all have some certain problems. I'm a big fan of the tension suture technique. However, in our series, we found that when you do it for an osteotomy, they take longer to unite. And I think that's because you're creating you're creating a fracture. There's a bit of thermal necrosis and there's a bit of bone loss with an osteotomy. So my experience was that they took longer to unite. If you're going to use that technique, add an extra circlage suture for safety, I'd recommend.
Right, okay, perfect, thank you. Prof, are we able to see those last two sort of, at least the pre-operative picture where x-rays where Jagwant has done an orthogonal plating?
Yes, 1 second. I'm just going to try and
it achieved
one.
Union.
Yeah, and if we go one slide back, please. Oh.
So it's important to talk about the approach, which Saurabh has already discussed.
Yeah. So there were two things. Yeah, thank you, Prof. Two
Another
things really.
patient, 53.
So two things really, sort of two observations to the whole panel, and let's see what we think about it. Now, first thing was, in this case, on the X-ray on the left, there is a capitulum and there's a posterior combination. So yes, Jagwant has beautifully used those screws, but then because of posterior combination, I feel we were obliged to do an orthogonal plate, to put a posterolateral plate to buttress from behind. So I felt if someone had done a parallel plate here, it may not have been a very wise decision. We'll see what Joideep has to say and Prof has to say. And the second thing really was, now can I label it as an articular surface fracture, a distal humerus articular surface fracture, rather than a distal humerus intra-articular fracture? So two things really, and I'll, Prof or Joideep, if you want to take the question.
Yeah, so I think you're absolutely right to call this a predominantly articular fracture. And do you remember what I said about when I was asked about hemi versus total elbow? Now, this patient's 53. I'm not proposing an arthroplasty, but in these severely comminuted articular fractures, you notice how the columns are spared. So this is one, if the patient was suitable, a hemi would be better, not a total elbow, just as an example. I agree that you need to be able to control the coronal fragments with your fixation, whether you use independent screws or a posterolateral plate. I like the plates. There are some plates that are posterolateral, but I call them hybrid plates because they have an outrigging device that comes and allows you to place lateral to medial screws. And that's the type of plate I would use. And in this case, I think it's right to use a medial plate as well because the fracture line goes out through the medial epicondyle, which it doesn't always do in these fractures.
Right. So basically, if it was the right decision to do an orthogonal plating, and parallel plating wouldn't have been a right thing to do, and it's an articular surface fracture.
Yeah.
Yes, but I do like having that lateral outrigger to allow me to put some parallel screws as well, because I think having fixation in different planes is very valuable.
Thank you.
I take your point, Joideep. I think we have the old style, the Acumet plates, but the newer plate from the Moderators and others, they have that capacity. Absolutely.
Thank you very much. Saurabh, do you want to wrap it up, please?
Yeah, sure. Yeah, first of all, thank you to all the participants for taking out your time. And we had some great speakers, and I hope it will benefit you a lot. And good luck for your exams. And yes, a big thank you to our faculty, to Professor Reit, and I wish him all the good wishes for his personal sort of problems that he's going through at the moment. Big thank you to Joideep, Jagwant, and of course, Professor Bijay, who's my mentor and who's always supported me. Thank you, all of you. Thank you.
Thank you, everyone. Great.
Thank you, guys.
Thank you.
Thank you.
Recording stopped.
Thank you, guys.
Thank you, Prof. Bijay. I hope it all went okay.
No, it was all fantastic. I think I just made a bit of a
Not at all, Prof. I must tell you that I have seen webinars where so much of problem happens that this was really went, and I think I'll suggest this pre-recorded is a very good way of making sure that you have, nothing wrong goes on the day. And the second thing is you can continuously answer Q&As.
And you can focus on what you're talking. So, that's why that's the difference. Thank you.
Fantastic.
Really
Thank you. Enjoy your Sunday.
Catch up soon, Jagwant. We haven't met face to face, but hopefully soon.
Yeah, we will definitely. Yes.
Take care.
Thank you, Prof. Bijay, for the opportunity. Good to see you, sir.
Thank you, everyone, for the opportunity. Bye-bye. Thanks, Saurabh.
Bye, Jagwant. Good to see you. Thank you. Thank you, Prof. Thank you.
Bye.